so far as or in relation to the cough basically is the personal history, right? Other than the part of the personal history, which is conventional that I have not entered here, is your habits and other thing that is second in the list. But nowadays, essentially, since we are talking about the corona and other thing, that's what I made travel as the first agent. The first point, basically, the history of travel is absolutely important, right? And if at all any epidemic going on there and the situation there, you must try and analyze. You must ask the patient. If patient says that I am from, if at all you are working in Mumbai, let's for example, and you got a patient of cough, you must ask him, did he travel in last couple of weeks, right? Because the incubation period almost all the virus and bacteria is less than 2 weeks. So history related to that, especially 2 weeks or something like that, very important. So you must ask that history of travel from epidemic or endemic area, right? That is very important, right? Now it is corona, earlier it was SARS, then it was some other virus, then it is maybe something else. So the history of travel is essential part of the personal history of a patient, which you are going to evaluate for cough, right? Then habits, obviously the smoking perhaps the most important. Secondly is alcohol. Third is there are many other varieties of tobacco that are being used. Most important habit about the cough, which I would like to highlight, is the history of exercise, right? Many times there is a variety of asthma which is precipitated by exercise, right? So it is the cough related to the exercise. The patient says that I go to the ground early in the morning, and once I start, say if he's a runner and completes one or two circles, he said then he gets a cough. So it is exercise induced asthma. Obviously, the other things are important, the smoking and other things, but this is something which is common and which is missed in the main course. So the habits are important, smoking. And secondly, in the habits, for evaluating the allergies, do not forget the chemicals that the person is using. Commonly, the deodorant, detergent, oils, and all sorts of scents and every other thing that is using the habits. And next is drugs. The common variety of drug which leads to the cough is ACE inhibitor, right? So the history of cough has to be asked in perhaps every patient which is not resolved, or any patient who is senior enough and taking the medicines, unlikely to take medicines for the hypertension. That's very common mistake made, that we treat the cough as if it is a respiratory origin. Actually, it is of the drug origin, and stopping the drug is the treatment. No amount of other steroids or antihistaminics or antibiotics or bronchodilators will help that variety of patient. What we need is to stop. The commons what we use is the losartan and captopril and telmisartan, right? All those ACE inhibitors and that group of drugs, right? Occupation, as I said earlier, occupation is perhaps one of the important issue, and it is basically related to that pneumoconiosis and industrial related allergy conditions, right? All those lung coniosis and other things. The last thing is the stress. Many a times there may not be obvious cause for cough related to the lung. It may be related to the mind, stress, psychology, into bracket hysteria. The commonest presentation of hysteria, especially in young female, is cough, right? They have got their own reasons for that, but do not forget the patient comes to you, especially if it is a acute cough. The patient was all right early in the morning, everything for the breakfast and every other thing, had a breakfast, nice breakfast, and once something happens and the patient starts having cough, the patient will immediately rush to the doctor, right? The situation is very scary. You try and find out the cause, there is no cause, right? If there is no cause in spite of proper investigation, remember hysteria should be the diagnosis of exclusion, but do not forget hysteria as a cause for cough, right? So the cough is varying nature, obviously it is dry, and go along with other complaints of usually breathlessness and restlessness and corpuscular spasm and the things like that. So stress leading to hysteria is very important cause, right? Coming to the family history, obviously the history of similar illness and any other illness, right? The, as you know, the allergies goes in family, the bronchial asthma goes in family, right? So all those things, especially if you are working with the city areas, then the family history doesn't mean your family members. You ask them whether any of your family members are having the problem, and the patient says no, right? Is that the end of the story? Definitely not, right? So many a times you will find patient or the patient staying in the hostel or paying guest, and the history of roommates having a similar illness should be asked, right? So do not forget to include your paying guest and the hostel mates or roommates into, or the classmates into the list of family history, right? So the colleagues and friends. Say if it is a viral, you will find the whole class, whole room, whole hostel, right, will have similar complaints. So family history should include the family members for hereditary or allergic disorders, but infective, especially viral. You should take note of the paying guest or the hostel roommates or colleagues, right? Or those who are working in the offices, the basically IT industry, you will find that the whole day they are cramped in some cubicles and something like that. So that should also be considered, right? And then that's about the history taking. What are the clinical situations where you should advise the further investigations, and what are the clinical situations where you should start treating the patients without further investigation, which does not, I mean, those situations we do not demand, does not demand the further investigation. So we'll go for the investigation part of the cuff basically. Routinely, almost always, every patient, if not in an acute case, but is advised for the CBC and ESR, right? Complete blood count is the cell count is the routine investigation done. And what do you find in a cell count? And if at all you order a cell count, when you see the report, how to interpret it, that is most important. The cell count, if it is normal, doesn't rule out anything, most importantly. Say, what is conventionally taught, if you have got a eosinophil, you have got allergy. You have got a polymorphonuclear, you have got a bacterial infection. If you have got a lymphocytosis, you have got a tuberculosis infection. That is true. But the presence indicates a disease, but absence does not rule out a disease. That is very important. You can have tuberculosis with perfectly normal cell count. You can have pneumonia with a normal cell count. You can have allergy with a normal cell count. Normal cell count doesn't rule out anything, but a change in the cell count does give indication for certain things like polymorphonuclear leukocytosis or neutrophils, bacterial infection, right? If you have got lymphocytosis, tuberculosis, many times you got tuberculosis is superadded bacterial infection, right? So you got lymphocytosis is raised, then you got neutrophils raised, cell count may or may not raise. So there is a variety of combination, right? But if you have got an isolated entity, you will get an indication of something, right? So if you have got eosinophil raised, obviously the eosinophils will indicate the allergic disorder. There is one more branch or indicator from the eosinophil. There most of the worms, right? Most of the worms like hookworms, threadworms, pinworms, roundworms, they have got respiratory system involved in their life cycle. When they go through the respiratory system, they produce cough and they produce eosinophilia, right? So also the schistosomiasis. So everything else may be normal. You do not know what is the cause of cough. You think whether it is allergic, it is otherwise. It is not allergic cough, right? It may be part of this infestations, what is called as. So you will get eosinophils. And secondly, monocytes, infectious mononucleosis is not that uncommon. You can have fever, mild or moderate, with a cough. You do the cell count, you will find monocytes raised, right? So that's about the cell count. Leukocytosis is very common. That's what I'm saying. The presence of abnormality may indicate something, but absence of an abnormality doesn't prove anything, right? Going to the ESR, that is erythrocyte sedimentation rate. Obviously, in acute case, it is expected to be normal, but as a disease process, which is chronic, more than a week's time, you expect ESR to be high. And ESR may not be of diagnostic value, but it has got a therapeutic or prognostic value. If you have got a disease like tuberculosis, where you expect the ESR to be raised, initial day you investigate the patient and ESR, it is say 50. The patient comes to you after 3 weeks and you do the ESR again. The patient may or may not show any clinical signs, but the decreasing ESR indicates good response to the treatment. So you must answer, along with other clinical parameters or radiological parameters. Radiology may be the last to respond, but ESR is likely to respond after 2 weeks. So ESR may not have a diagnostic implication, but may have therapeutic implication. That should not be overlooked. More importantly, ESR needs to be interpreted along with the value of hemoglobin. Obviously, somebody who is anemic, let's say hemoglobin of 8, his ESR is bound to be high, right? ESR should not be interpreted in isolation. Very importantly, ESR should be interpreted with the knowledge and information related to hemoglobin. So for a male, let's say for example, if the hemoglobin is 14, the ESR is 10. But what about if the hemoglobin is 11? The normal ESR is 30. Do not forget. So for every 1 gram decrease in the hemoglobin, ESR goes up by 10 approximately. Do not forget. So the ESR should not be interpreted independent of hemoglobin. So if somebody is hemoglobin of 8, normal ESR is 60. Do not forget. So the ESR may or may not be indicative of anything, but it will, with a normal hemoglobin level, the raise in ESR indicates inflammation, in your case infection maybe, and decrease ESR indicates that the patient is responding well, right? So coming to the, which are the clinical situations where you will advise the patient for X-ray chest. This is very important. The first and foremost important is cuff with expectoration, yellowish, should go. Unless the patient is diagnosed earlier, the cuff with expectoration, that is yellowish in color or reddish in color or greenish in color, should be submitted for X-ray chest to rule out any underlying thing. Just absence of bronchial breathing, absence of, the air entry normal and equal and other, all clinical signs should mean the X-ray should precede over the all other clinical things, right? The absence of signs doesn't mean that patient should not be submitted for X-ray chest. Every patient with a cuff with LS expectoration should be submitted to X-ray chest. And most important, every patient should go to the X-ray chest is cuff with chest fan. Mute करा ना, mute नहीं कर लगा, आवाज येतात. So the cuff with chest fan should be submitted for X-ray chest, so that you will find it easy to diagnose, localize, quantify, and monitor patients, right? So the X-ray is not there, absolutely irrational to submit the patient of upper respiratory tract infection for X-ray chest. If at all required, you can advise the X-ray paranasal sinuses, water sweep, that is called as. So the indication for X-ray chest, what I'm talking about, first thing is hemoptysis. X-ray, the cuff with expectoration, which is yellowish in color, cuff with chest pain, everything must go for, and cuff with associated complaints or where you cannot diagnose. All these patients should be submitted to X-ray chest, right? Secondly, what are the indications for X-ray? The CT chest. Many a times, early in the course, even the pulmonary tuberculosis will show normal X-ray chest, right? Should we wait for the X-ray to be positive so as to diagnose tuberculosis? Definitely not, right? Your job as a physician is to diagnose the clinical condition as early as possible, right? X-ray chest is definitely useful, but may not be always, may not be early. So in early case, if at all you think you need, the CT chest is advisable. And what are the clinical situations where you should advise the patient to go for a CT chest, right? High index of suspicion, of tuberculosis with X-ray negative should be subjected. High index of suspicion for CA bronchus with X-ray negative should be submitted for CT set, right? What happens? Our doubtful images on X-ray. You advise the patient to have X-ray chest. You do the X-ray, and the X-ray comes with some mottling, very 2 or 3 shadows, upper or lower, or some scattered shadows, and you don't know how to interpret, right? You do the inspiratory X-ray, the patient, the X-ray may be negative. You give the overexposure, the X-ray may be negative, and the things like that. And those things can be seen on HRCT, right? Or early bronchiectasis, right? These are the things which can be seen only on CT chest. The many earlier tuberculosis lesions may not be visible on X-ray chest, but can be diagnosed only on CT chest, that is computerized tomography. So in these are the situations where you should advise X-ray chest, and certain situations, obviously there is no rationale in advising X-ray chest showing fibrocasis tuberculosis right upper lung. Absolutely no rationale. There is no rationale in submitting a patient to X-ray CT chest for a classical pneumonia or pleural effusion. Absolutely no rationale. On the contrary, if you have got a effusion, if you tap a effusion, and even if the tap becomes dry and the X-ray shows some opacity, then so as to diagnose that particular extent of the disease, you can go for X-ray chest. I mean the CT chest, right? There are two different sets, right? Coming to the bronchoscopy, you have got hemoptysis and X-ray chest is negative, CT is negative. Submit the patient for bronchoscopy, right? Because all the internal lesions which are lining the internal part may not be seen on either a CT or X-ray also, right? Or maybe something doubtful may be seen on CT, may or may not be on X-ray. That should go for bronchoscopy. Or what you need, histopathological diagnosis, CA bronchus. Or you want to have a specimen for bacteriological diagnosis, for parasitic diagnosis. Or third is foreign body, as I said earlier. The foreign body, you have got a small peanut lodged in the secondary bronchus that refuses to come out, right? The commonest is right lower bronchus, where the small food particle may be lodged, and then you can put in a bronchoscope and take out the foreign body, right? So these are the different indications. For X-ray chest, localized pain, cough with yellowish expectoration, and obviously the tuberculosis and suspicion of pneumonia are the indications. For CT chest, when there is no clear something which is not seen clearly on X-ray, doubtful shadows, the post-tapping shadows, right, and high index of suspicion of CA bronchus, and for bronchoscopy, all hemoptysis patient preferably. And obviously, if you see the CA bronchus, I mean the fibrocavitary tuberculosis with hemoptysis, with a copious hemoptysis, there is no indication for bronchoscopy, right? For cytological histopathological studies, like in CA bronchus, like getting a sample in fungal infection of the lung, and obviously the endobronchial tuberculosis, where you need a bronchoscopy, and foreign body, do not forget, right? So that's all about the cough and history taking, which I wanted to tell you. सगळ्यांना बोलायला दे ना, unmute करा ना. You can ask me questions if at all have any. Any questions? Can you hear me now? Students, can you hear me? Somebody please respond.
Yes, sir.
Any queries? Any queries? Anything which you have not understood? Anything which you have found difficult? What? Hello? Anything that you have not understood, not heard, not you want to be repeated, you want something to be added. This is nearly 2 hours, 1.5 hours. बोलिए. Students, any queries? Any queries by anybody? Shall I conclude? Shall I conclude? Thank you.